Hi, this is John Kanellopoulos from Athens, Greece. I'm pleased to share with you my keynote lecture at the past ASCRS this past April 2022 at the American Society of Cataract and Refractive Surgeons in Washington. Thanks so much for watching.
So we're going to actually move on to our next talk, and that's by John Kanellopoulos, Cross-Linking and INTACS, what are the best practices, and how do I start incorporating this into my practice?
Thank you. Thank you, Kathy, and thank you, Marjan, for inviting me. It's really great to be back in flesh and meetings. Got a little rusty through the years. So I do consult for Alcon, and I'll be speaking a little bit about topo-guided, not as well as Ron did. And this is an interesting subject because outside the U.S. there's different kind of intracorneal rings that are used. So some of the slides I'll show you are with Kera rings or outside the U.S. products. Sorry for those of you who practice in the U.S. INTACS is the way to go here. We heard excellent talks today. And I think that if you take home, as far as keratoconus is concerned, the imaging, that is enough. I practice in an environment in Athens where we looked at our 3-year cataract cases. These are people that walked in with cataracts in their 60s, 70s, 80s, some in their 90s. 12% of them have keratoconus diagnosed by the pentacam. So this is the environment that I practice in. It's like walking or running through a landmine. So it has to be very much the beginning on how to pick these keratoconic eyes. These are the diagnostics we have in the Athens office. We have 50 machines. There's plenty of them in the floor here. In our New York office, we have 1/5 of that. But nevertheless, we have developed an interest in imaging. And this is a medical legal case. I was involved in the US. I was called in as a medical expert. This was a LASIK case in a young gentleman that carried the diagnosis from some very, very big names and esteemed colleagues and friends of mine as post-LASIK ectasia. And it looks like it. Inferior steepening, this is post-LASIK. Crucify the doctor. Look at the pentacams. And we heard about this before. There's no correlation of the steepening with the pachymetry and not at all with the posterior elevation of the cornea. It just correlates with the anterior elevation of the cornea. So this is just a decentered, mixed, astigmatic LASIK. And it is, if we're considering cross-linking, it is a little bit silly, and you pardon my French here, that we use one treatment for all ectasias and keratoconus. It's as if we're using one IOL for all cataract surgery. So you only have a plus 21 in your OR and use it for all patients. And the things that we still do not know about ectasia is that we don't know how much ectasia this patient has, how abnormal the biomechanics of that patient is, or how abnormal it will become in the future. So we still, even outside the US, where we've done a lot of work, I've personally cross-linked over 10,000 patients. We know very little, but we know a few things that we can guide ourselves through. This is central cloudy dystrophy of Francois. And this is just an example of how it can trick sign fluke imaging on the bottom left. Sign fluke goes crazy because it creates a little cloudiness, and sign fluke imaging requires a pristine, clear cornea. By the way, central cloudy dystrophy is a very benign cornea expert thing. We have it in our boards, and that's all that's important about it. But reflection topography, remember, does not give you central data. So this is a little bit with the rule astigmatism in the middle placido disc image. But there's no data in placido disc centrally, so there should be a black spot there. Reflection topography with the Cassini shows a little bit against the rule astigmatism. Why is it important in this case? I was doing cataract surgery, and I like to be with the rule a little bit post-op. These are, again, my financial disclosures. So let's talk about intracorneal ring segments. Again, a lot of questions. Is it really keratoconus, the case you have to treat? So this is very important. I would love the day that we stop describing keratoconus as the non-inflammatory progressive thinning of the cornea and we start speaking real medicine. Keratoconus is something I inherit and I induce by rubbing my eyes, period. That is what keratoconus is. So once we understand that, we have to look into imaging, make sure that we're looking at a real keratoconic patient, and then make the decision. Of course, the pathway is very difficult. You do the rings first, you do the cross-linking first, you do them simultaneously. What type of rings do you use? You're stuck with INTACS in the US. Are you going to use 2 rings, 1 ring? What size rings? There's a lot of nomograms. I think the late Joseph Collins, a French colleague and friend who passed away several years ago, unfortunately, very young, nomogram on using INTACS is still probably the golden rule. We've shown through the years that there's some problems with using synthetic material for intracorneal work. And I think the inlay disaster in the US is another testament of this. This is our attempt showing xenograph porcine INTACS within the cornea in an ex vivo study we published several years ago. But I think it was Susan Jacobs who brought in the excellent idea of using allograft-made INTACS for this procedure. And this is something we published many years ago, Cornea in 06, and then Journal of Clinical Ophthalmology 13 on some severe complications you can have with EPMMA material. This is a case of that I saw that was implanted 40 years with INTACS for keratoconus, not by me, this was in Greece, and 14 years later, this patient did very well. All of a sudden, he started going into keratolysis. And he perforated, and you can see here I had to do an annular graft to correct him. A lot of tip dancing here, but this is not a very simple procedure. Kudos to Susan. I think she had a talk here into using allograft material. It's called Kyre's procedure. This is using cross-linking in one of my cases after INTACS, because INTACS are probably the most effective way of getting an immediate result. Your patient will walk off your surgical bed with great vision and a reshaped cornea. And there's nothing like it available today. Topo-guided may help, but it'll take a while. We heard that the healing is non-predictable. And of course, the changes, again, are enigmatic. There's an X factor how much topo-guided and CXL can correct. It could be from 6 diopters flattening, and we reported this, all the way to 25 diopters flattening. I don't necessarily think that's a bad thing, but it's unpredictable. So here we're seeing cross-linking in a patient who had INTACS, and it does work. This is a case combining INTACS and cross-linking. And again, here the questions are, where do you place the riboflavin? You can put it in the channels, or you can use the traditional technique, scrape the cornea, instill the riboflavin, and cross-link at the same time. I want to thank Caroline Hosha, who gave me these slides on her work with INTACS and keratoconus. And if we can see some of these improving with INTACS, there's another case before and after on the bottom, and the difference on the bottom right. And if we can play this video fast forward, this is Caroline's technique of using the femto to create the channels. It's a very straightforward technique, and the femto is the way to go to achieve good depth, because that's the key thing of having the INTACS to work. Although you do need 400 microns of cornea for them to work, if it's under 400 microns, you don't have enough tissue, and we're seeing how fast of a surgeon Caroline is, and also how easy this is to perform, and it's very effective, works right away. This paper by Peter Hirsch shows that if you do concurrent or sequential, the results are pretty much the same with INTACS or intracorneal ring segments, and again, look for deposits. They stay even if you remove them. The good thing is that you can remove it. This is a reversible procedure. Most of what we heard today is not reversible. And again, I cannot stress more that keratoconus or ectasia or any ophthalmologic problem needs cornea epithelial mapping. And we did report the literature on how normal mapping and abnormal mapping is. This is, of course, the case that Ron alluded to early on. Our go-to procedure is the Athens protocol. We do perform a topo-guided partial in refraction PRK to normalize the cornea. In Europe, we do a PTK. In the US, I treat my patients with a modified wafer-optimized hyperopic card and the Contura card with Alcon, so 2 cards to treat transepithelially. So I shoot the Contura card with a minus 2.5 myopia more to treat the epithelium centrally, and then I go in with a plus 275 hyperopic wavefront optimized through the epithelium and then do cross-linking. So we presented this at this meeting. You can look it up. It's a smart way to bypass the limitation that you cannot do PTK in the US. And these are our 10-year results with the Athens protocol that do show that stability is attained in about a year with these patients. And 10 years out, they do flatten a little. 2% of the patients flatten a lot. And some of the patients ended up with keratometry of 32, but you can still do hyperopic correction on these patients. And I'm gonna close here with some of these examples. You can see how dramatic. You cannot get the result you're seeing on the right if you do the procedure sequential. Cross-linking will give you about 2 diopters flattening. With the laser, you flatten 2 to 3 diopters. So that's a total of 5 diopters. We're seeing here 15 diopters flattening, and it is the combined procedure that gives you that synergy. Although you do have to weather the fact that the refractive result may be unpredictable, so you cannot promise emetropia. So this is the New York office last month, and this is a patient that we presented this actually at this meeting, and I'm closing here with a trick of how in the US you can perform transepithelial topography-guided PRK and keratoconic eyes and use the epithelium as a masking agent. So first, the Contura treatment, adding arbitrarily a -2.5 at 6mm diameter, and then with a separate card, a wavefront optimized card, a plus 275 to attain a transepithelial approach to normalization. And this is that patient a month later, before, after, and the change. And that's all I had for today. Thanks so much for inviting me. This is great.
Thank you so much.
That was wonderful. So have you moved away from INTACS secondary ring segments altogether with this new topography-guided technique?
I will use INTACS if the patient is in dire need for an immediate result. I think they are still the most immediate in efficacy way. I'm very concerned, especially in the population that I treat, who are avid eye rubbers and have patients tape themselves how they sleep at night. I know it sounds silly, but it's very, very enlightening. So I'm very concerned about the long-term stability of the rings in the cornea. Using allograft material, I think, will be the way to go.
Great. Wonderful. Well, thank you, everybody, for being here. Thank you to our esteemed panel. It was excellent, and hope we see everybody again in San Diego next year.
Can we keep the panel up here for a second? Can you guys stay up here for just a photo?